Hey, Miss Peggy.
Hi.
I'm sitting in the dark here. I'm gonna turn on some lights and then I'll turn on my video.
Okie dokie. Very good.
Okay.
There you go.
Doing?
Is this the first time we've met via Zoom?
Yes.
Oh, okay.
Yes. Yeah, I don't think we've seen each other in person in a few years.
Yeah.
I was still a student at LSU or just after I left LSU. So I think it would have been 2013. So
Oh, okay.
yeah.
I didn't come back full time until 2015.
Mm-hmm.
From 2012 to 2015, I was in DC full time. So,
Mm-hmm.
but anyway.
Well, somewhere in there, it's been at least 5 years. Nice to see you again. I love your painting of the herons in the swamp.
Oh, it's
So beautiful.
my cousin. She's this phenomenal artist. She lives in Lafayette.
Oh, wonderful. She's really drawing on her landscape, isn't she?
Yeah,
Yeah.
yeah, she does. She's phenomenal. I mean,
What's her name?
Paula Barilo. Um, and her website is, well, on Facebook, Paintbrush by Paula.
Okay.
She's just fantastic. I mean, I didn't get any of those genes at all. She plays the piano. Her kids are talented. Her grandkids are talented. Her siblings, they do all this phenomenal artwork, jewelry, you name it. You name it.
Well, you're from the policy side.
Yeah.
There's a lot of greatness in the honor race.
Yeah. I have no talents at all. I'm not artistic or anything. But
I like to do I like to do crafts. I like to make usable.
do you?
Yeah, so I knit and I quilt and I like to bake and all that kind of stuff. The students in the program know that as a young person, I was pretty heavy into Martha Stewart.
Really? Like Snoop Dogg.
Yeah. Yeah. See, I'm of the generation where both things were happening at the same time, Martha Stewart and Snoop Dogg. And
Yeah.
It's the both.
Yeah.
So anyway, yeah, I hope you saw my email. The kids in the program are scholars, are from all kinds of different professions and at all points in their careers. And so I think if I always say, like, if you ever had an opportunity to tell everybody exactly what you wanted them to know.
Right. I spent a lot of time deciding what to tell them, and I thought giving them some fundamental basics of what is policy, just the fundamentals. I've been teaching policy for like 15 years, a long time.
Yeah.
And I have a gazillion PowerPoints. So I tried to give them the basics. And I mean, I know we talked about maybe doing a second. I mean, there's definitely tons and tons of more material, but I'll, leave that to you to decide. It's not, it sometimes it's not necessarily the most engaging thing to talk about the fundamentals. Like when I talk, I do one for the medical students on physician advocates.
Uh-huh.
You're not just, the title is physician advocate, but it could be advocacy for anybody. And
Hmm.
that one's a little bit more interesting. And when I talk about policy analysis, like how do you take a problem and analyze it and walk it through
Right.
being a policy? Today, I'll talk more about what is a policy and what is the process of
I think
getting
that'd be
to
great.
be a policy.
Yeah. I think that'd be fabulous. You know, my specialization before I came to this became mostly about mortality surveillance and with
Oh,
child health population.
uh-huh.
Yeah, and so I'm no stranger. I worked at the city of New Orleans, and then I worked at the Bureau of Family Health for a few years, and so
Mhm.
stranger to both local and federal partnerships. And
Yeah.
it's such exciting stuff. It's such exciting stuff. When you get into it, it's so fun, and it's really where the rubber meets the road of how and of the how and the why things look the way they do in the American health system.
Right.
And it's such cool stuff. And so that's why I wanted to bring you in. And
Mhm.
like for my part, I think what I'm going to end up teaching is for this semester is going to be a session on how to design a real program.
Oh,
How to think about your outcomes before you start, and how to get people to learn what you want them to learn. Is it because people always suggest if you want them to do things differently, well, let's just educate them. And so how do we get beyond education and those kinds of things? And so I'm still working on putting together. I'm not going to do it for another month, but I realized that I'd been asking everyone to give their dream lecture, and I hadn't done my dream lecture yet.
yeah.
Really
Wow.
excited for this. So do you want me to introduce you, or would you like to do your own introduction?
No, you can introduce me. You don't. If you have the bio from the website, just don't read all of that.
I'll read the abbreviated version that I.
Yeah,
Yeah.
because people don't want to hear all of that. Yeah.
Good. Okay, people are starting to pop in.
Oh, good. Some of these are current LSU medical students or MPH.
Yeah.
students. Okay.
Yeah, both. Some are both in either department. We have audiology, and we've got folks from
Mhm.
got Xavier Pharmacy,
Oh,
the psychology. We've got UL Health Administration.
wow, that's
Yeah,
impressive.
yeah. We worked hard on our outreach. Next is to get some of those Delgado certificate students in.
Yeah, I was going to say to you, Dana, the program, it just took off.
Oh, wonderful.
They're about to graduate the third cohort, and some of them have already become certified as health coaches. Many of them have master's degrees. So we're really excited about that. We're still working on the Health Navigator program.
Wow.
That's going to be maybe another year before we'll have our first cohort.
That was the Health Navigator was the 1 year, right? Is that?
No, the coach was the 6 months. The
Oh.
navigator is 2 years, actually.
So the navigators are the ones that would be wonderful to have
Yeah,
in this program.
they will have an associate degree in.
That's so cool.
Yeah.
And then the other one is a certificate in community health.
No, the other one is a certificate in health coaching.
Health coaching.
And they can, I'll have to send you the link, but I'll also send you a Washington Post article. That was
Please do.
on that. But once they complete our program successfully at Delgado, they can sit for the National Board of Medical Examiners exam to become board certified as a health coach. Once they become board certified as a health coach, they probably will be eligible to bill for their services pretty soon, because the American Medical Association is working right now with the VA on research measuring for outcomes as a result of those services, with the intent of creating a CPT code that could be
Wonderful.
reimbursable.
That's wonderful.
Yeah,
That's really good to hear.
I know Jack.
Yeah, you may be familiar with more than a few of these folks.
I direct the population management course for first year medical students. So that's how I know Jack.
Oh, there you go. Jack is a great writer.
Hi,
Hi
Jack.
there. I'm actually trying to get onto my computer, so just give me 1 second, okay?
I think Jack had my health system and policy course at the medical school too, maybe.
I took HPSM with, I can't remember her name, but boy, was she funny. She had such a good sense of humor.
For policy,
Yeah.
Christine Brennan.
No, HPSM.
Oh.
Her husband worked there too. She was.
Oh, Angela.
Yeah, Dr. Chu.
Yeah.
Chu. Yeah.
Yeah.
Really instilled in me the utility of humor in the profession.
Yeah.
So it's right at 6 o'clock, and I'm just going to give folks another minute or so to tumble in. I like to say that the waiting room on Zoom is a little bit like popcorn. You just got to wait until it's percolating so much. Got great attendance tonight.
I see that.
I always feel like I should have hold music up.
Yeah.
I'm going to make it so you can share the screen.
Okay.
Oops. Stop share. Okay, now you can give it a go.
Yeah. We go to the okay. Can you see that?
It looks beautiful.
Okay, good. Good. Jack has probably seen some of this at some point.
Well, he'll have to not tell.
Okay.
Mhm.
Be like the first time.
All right. I'm gonna take my eye. Oh, I knew it the second I said I was going to take my eyes off of it. It made me another one. Okay, so let's get started here. All right, guys, thank you so much for joining us tonight for Fundamentals of U.S. Health Policy and Policy Analysis. Peggy Honore. Dr. Honore is the AmeriHealth Caritas General Russell Honore Endowed Professor at LSU Health Science Center School of Public Health and the School of Medicine. She has extensive leadership experiences in private industry, healthcare, and public health and higher education. Research and teaching priorities for Dr. Honore include population health, policy, workforce, quality, and health equity. She created the Health Policy Honors Program and the Population Health Management Clerkship for first and fourth year medical students. Her current health equity research topics are focused on implications of COVID-19 on diabetes and the impact of air pollution rates on the infection and death from COVID-19 in Louisiana's Cancer Alley. Whew. Try saying that a few times fast. Global experiences of Dr. Honore include invited memberships of World Health Organization Coalition of Partners for Strengthening Public Health Capacities and Services in Europe and the African Diaspora Universities Research, Instruction and Engagement Task Force, WHO consultancies through 2018 included missions in Ukraine, Denmark, Greece, Helsinki, and Slovenia. So I'm going to stop reading her bio because it will go on and on and on, and I want to save some time for her actual talk. But just know that Dr. Honore is somebody that I am extremely excited to hear present to us tonight. And I'm going to go ahead and turn it over now to her. Thank you so much for being here, Dr. Honore.
Thank you. And my sincere appreciation for being invited to lecture to the group tonight. And I hope that the topic will be of great interest to you. And what I'm going to present on is the fundamentals of health policy. There are many, I've been teaching policy for over 15 years. So there's many things about policy that I can present to you, but I thought giving you in this lecture, the fundamentals would be appropriate. I have one of my former students in the Zoom tonight. So Jack, I hope that you can stay engaged because some of this you've probably seen before. But anyway, let's get started with talking about health policy fundamentals. So exactly what is health policy? I've had people to tell me that policy is like this big 800-pound gorilla in the room, a very abstract concept that they just really don't understand. But by definition, health policy is authoritative decisions regarding health or the pursuit of health made in the three branches of government: legislative, executive, and judicial branches of government. And with the stated intent to direct or influence the actions, behavior, or decisions of others. We have a lot of information in the news lately on the three branches of government, the separation between those three branches of government as designed in the Constitution. So you get to see some of that in this lecture. So generally, health policy is generally established in the federal, state, or local levels of government. Although, as we'll see on another slide that I have someplace in here, is that you can have policies at the organizational or institutional level as well. You can think about at the organizational level, especially with health insurance, well, what policy is that corporation or institution going to implement regarding health insurance for their employees? That's just one illustration of the concept of policy that's not set at the federal, state, or local level. Or think about when we had mandates, before we had state mandates for masks, some organizations had their own individual mandates for masks. It was policy that established that. Policies generally affects or influences a group or class of individuals. You could think of, policies that relate to physicians, policies that relate to the poor, such as Medicare and Medicaid, or policies as it relates to children, newborn screening policies, mandatory newborn screening policies, or mandatory immunization policies for children. So policies, in essence, are a potential solution to a problem. I mean, typically, people don't wake up on any given day and say, you know what, I'm going to implement a policy today. Typically, there is some problem or some issue that that warrants the development of a policy. So it's in response to addressing a problem, eliminating a problem, or lessening the impact of a problem. You can think of, let's think of the border wall. There was a problem. The policy, we're going to build a wall. Does that policy match the problem? Do we really need a border wall, or do we want a border wall? But typically that's the way it works, where the policy is in response to a problem. Let's talk about problems. Problems are situations that are considered unacceptable and promotes demands for change. We could think of healthcare reform. We needed healthcare reform, insurance reform for over a century. It was a problem. It got to unacceptable levels with the number of uninsured people in the United States, but also with costs. I don't necessarily think that we've, that the Affordable Care Act necessarily addresses totally the issue of cost, but it is at an unacceptable level. Problems presented with a sense of urgency are more likely to overcome public uncertainty about government action. Think of 9/11, or think of coronavirus. I mean, it is that those are problems that definitely have a sense of urgency, that something needs to be done. I don't think at any other point in time have we seen so much policy towards getting money in the hands of the public. There's been 2 checks dispersed already. Biden is talking about another check. There other policies that have been put in place to help employers keep their employees on the payroll, but this is happening because it's a sense of urgency. Now you can say it's been like 6 months in between when anything was done because of political dynamics. We're going to talk more about that a little later, but politics definitely influences the policy making process. Government responsiveness to a problem depends on the level of risk, but also on who is responsible for the problem, such as healthcare as an individual responsibility. Is it an individual responsibility? Is it a societal right? Should it be a benefit of a job, of having a job? Should it be a market commodity? I mean, in America, we treat health insurance like a market commodity, and you get it as a job benefit because it's not considered a right. It's not considered as an individual right. And this is what has really been a barrier to addressing the health insurance problem in America. Unlike in other countries, I mean, I've been to countries all throughout Europe working with them on public health and health plans. And, you know, we're distinct because we treat health insurance like it's a market commodity. And just like you trade for grain or anything else in a marketplace, that's not how it is in the rest of the world. And even though I get invited to go work with these countries, the first thing that they'll tell me is that we don't want to be like the US. We don't want that system. So we are different. Problems are more likely to result in incremental policy change via government action, as opposed to comprehensive change. Although President Obama was encouraged not to push for comprehensive health reform. He was encouraged to do something more incremental, like don't change the whole system. Let's just focus on pre-existing conditions and continue down this road of a patchwork of health insurance coverage versus something more comprehensive, even though in a lot of ways, a lot of things have gotten picked off now. So we're kind of still with this patchwork of health insurance coverage, but it is better than it was previously. As I mentioned before, policy is not only made at the federal, state, or local level. Yes, you can have policies in the private sector, corporations or organizations, definitely can. So don't get tripped up and think, well, if it's a policy, it has to be in government. No, policies exist, definitely exist beyond government. And there are multiple forms of health policy. Well, of course, there's laws, okay, like the Affordable Care Act, PL, meaning public law, 111-148. If ever you pull up a public law, it's going to show that. And that simply means the interpretation for that is it's the 111th Congress, and it's the 148th law that was passed in that Congress. That's all that means. You can also get policies through rules or regulations established by administrative agencies responsible for implementing laws. So just to give you an example, you could think about, and this happened to me about 15 years ago in an agency where there was a change in the panel of tests for mandatory newborn screenings. So the law was to increase the mandate in the state for which tests should be performed, but it had no instruction, and rightfully so, because it's not going to have this level of detail. But so, okay, we're going from 6 mandatory tests to 20 mandatory tests. That's the law. It has to be done that way. But it doesn't say how much to charge the parent for that test to be done. So you would do that through the rule-making process. You could also have regulations, like there are many regulations that affect healthcare facilities. It may not be specifically stated in a law what those regulations should be, so you would go through a regulatory process to do that. So that's, I don't want to get too deep in the weeds with you on this, but I think it's important that you know that a policy by definition is not just a law that you would see enacted by a legislative body at the state, the federal, state, or local level. There definitely is politics in health affairs. Politics definitely influences how and when you turn solutions into policies. There have been textbooks and many papers written on this topic, and we can see, because now national debates and state debates are so inflamed right now, we can see how being on one side of the aisle or another, the dynamics between both sides of the aisle and trying to come to some agreement, some consensus on what the policy should look like. There was great debate for 6 months about, should we give more money? Are we going to give $300? Are we going to give $600? But it was the political influences that was controlling that discussion. There's a wonderful paper that I really like, and this should really be 2020. I don't know why I put 2019. This paper was just done late last year by Jessica Montez, and I'm bringing her to LSU this month to present this paper to my policy class, and it's U.S. state policies, politics, and life expectancy. Because I think it's very, very important for students of policy to understand that policies do have an impact on health. And the ultimate measure of health, life expectancy. And there have been papers, research before on this, but I really like the way that they did this in this paper. And here's some of the findings. State policies play a role in the decline of US life expectancy. And I'm going to show you some statistics on Louisiana life expectancy. Life expectancy changes were associated with state policy changes along a conservative liberal continuum. So they categorized policy as being conservative policy or liberal policies, saw and identified which states had what policy, and they tracked and measured life expectancy. States with more conservative policies were more likely to experience life expectancy reductions. Think Louisiana. State policies on tobacco, labor, the environment, immigration, civil rights appear to be key for improving life expectancy. Some examples, the impact of a living wage on economic well-being. In a city like New Orleans, where the vast majority of the population does not make a living wage, and we can say the living wage is $15 an hour, but I don't even think $15 an hour is enough to have good health and economic well-being. But even when you give people access to health care, if they're not making a living wage, how much influence is that going to have on improving their overall health? If they're on medications and they're not making a living wage, and the medications aren't even provided for by their insurance coverage, they're not even going to be able to afford the medications or afford to eat healthy, nutritious foods. It also impacts health behaviors and definitely birth outcomes as well. Improvements of 2.8 years for women and 2.1 years for men if states had less conservative laws. And I'm not presenting this as a political statement. I have no skin in this game, and I don't think these researchers do either, because there have been earlier research that said that has shown findings comparable to this. Downstream factors such as economics, medical care access, and behaviors that are influenced by policies play a key structural role. She's coming to my class. It's in late Jan, it might be early February. I don't know. Robin, I can send you, if anybody, I'm really intrigued by this research. If anybody wanted to pop in via Zoom and hear her, I'm definitely willing to make that available. This is just data, a chart that they made available. They call it the policy liberalism score. And you can see where a state like Connecticut showed great improvement here, as opposed to a state like Oklahoma, who had more conservative scores, more conservative policies over here, where they did not have the degree of improvement in life expectancy. And here's Louisiana down here with the green arrows. So you can see we're on the downside of life expectancy compared to some of the other states who are on the upswing with that. And here you have Mississippi down at the bottom as the worst. Louisiana and Mississippi are typically fighting for last in everything. I think what finally helps Louisiana to some degree is Medicaid expansion. Although with the 2018 state health rankings, we were still 49th and Mississippi was 50th. So it has helped, but not to the degree like we need it because of some of the other things economically, and other social factors where we lack. Let's talk a little bit about the impact of policy on health determinants and on health. And we can see in the middle here, we have social determinants of health, and health policy. So if you have health policies that are influencing better outcomes in economic stability, such as income, in neighborhood and physical environment, such as housing, transportation, walkability. In addition to living in New Orleans, I also live in Rockville, Maryland, and it is different like night and day, the walkability scores in a place like Rockville, Maryland, and in a place like New Orleans. Different like night and day. Definitely education policies that directly relate to improving educational opportunity, especially early education. I'm not going to read through all of these. Well, definitely the healthcare system. You know, I guess the best thing that we have going for us in Louisiana now is Medicaid expansion, provider making health coverage and provider availability. Definitely, but definitely health policies that impact the social determinants of health definitely will impact health as measured by health outcomes. You know, reducing mortality and morbidity, increasing life expectancy. Jessica's research supports this. It directly supports this. Any questions so far? I'm going kind of fast, but if y'all have any questions, just jump in. This is another good chart. It shows debts attributable to social factors compared to causes of death. So what this is showing is that there's more debts that can be attributable to having low education than having a stroke or lung cancer or chronic lower respiratory disease or unintentional injury or renal failure. That all of these social factors, low education, low social support, racial segregation, income inequality, poverty, childhood poverty in New Orleans is some of the worst in the entire country. It's somewhere above 30%. It's some really high amount. And personal poverty, but also neighborhood poverty, when the whole neighborhood is in poverty. So when we talk about the social determinants of health, it's not some soft concept that doesn't impact how we live and how long we live. I'm glad to see this degree of attention probably going in research to the social determinants in the US. It's been happening in Europe for a very long time, But I think we're very mistaken if we think that we can just give people access to care and suddenly everything is going to be better, because it's not. When I was at HHS doing the debates on the Affordable Care Act, I used to sit in my office all the time, you know, we get all of these updates and things, and I'd say to myself, I wonder when these people are going to figure out that giving people access to care alone is not suddenly going to raise the US from being like 38th or 39th in the world with life expectancy or infant mortality. Access alone, medical care alone is not going to do it. It's just not. One really positive thing, and you probably can't see this too well, but they're now building codes, CPT codes, where you can actually keep track in a medical practice on social determinants of health diagnoses. And some of those are here in this chart. And some Medicaid managed care organizations and probably other insurers as well are now paying for things for patients such as food, transportation, housing. How healthy do you think, or how much do you think you can improve the health of a homeless person? You can provide the care. They can be in the hospital a couple of days, and then they're discharged and they're going back to live on the street. How long is that person, how long is it going to take before that person's health deteriorates again? So some insurers are beginning to pay for things like housing. Policies shape opportunities for a healthy life. And we consider this a concept called health in all policies. So health, I guess this is a financial one. This is transportation, education, medical care, and environment. Many areas of public policy, doesn't say health policy, can impact health, and health can impact many different policy goals. When I worked in state government, when this concept was fairly new, and whenever someone introduced a bill from one of the other agencies, I was in health, but if transportation, agriculture, anybody else wanted to introduce a bill, they had to circulate it through the Department of Health, so a determination could be made if that policy was negatively going to impact health. So by definition, health in all policies is a collaborative approach to improving the health of all people by incorporating health considerations into decision-making across sectors and policy areas. So this is what I explained to you. The goal is to ensure that decision makers are informed about the health equity and sustainability consequences of various policy options during the policy development process. A health in all policies approach identifies the ways in which decisions in multiple sectors affect health and how better health can support the goals of these multiple sectors. Think about agriculture policy. So, you know, the American Public Health Association is very much involved when things like the reauthorization of the Department of Agriculture policies go before Congress, because agriculture, the production of certain kind of foods, the subsidies of certain kind of foods, it has an impact on health. So we've been fighting the obesity problem for decades. But as long as we're subsidizing the foods that help, that are used in the process that aid people with having an unhealthy diet, then that definitely has a negative impact on health. So why are we subsidizing the production of those food products? I'm just giving this to you as another illustration of health in all policy. Agriculture policies definitely have an impact on health. Gun policy, impact on health. Transportation policy, impact on health. Education policy, impact on health. So let's just look at Louisiana. So since I've talked about, policy and health, this is Louisiana's ranking in out of the 50 states for the last 30 years. I mean, this is 19 right here, and we were still 49th. So when the United Health Foundation started ranking the states on health status in 1990, the Louisiana was 49th. It jumped up to 50th, and you can see here, it never jumped up very much. I really think that in this period, it was data problems, because you can't tell me 3 years after Katrina that we improved that significantly. I don't think so. But as you can see here, it's in 2019, we were 49th. We were 50th in 18, 49th here. So it's embarrassing when you're sitting at the federal level and these reports come out year after year after year, and your state is constantly at the bottom. There's something wrong with that. Something is not working. And I don't even think that people know that we're at the bottom. I really don't. I mean, we have this wonderful lifestyle in Louisiana with, Mardi Gras and Jazz Fest and King Cake and everything else. So we're happy not knowing what health status is for us here, but that's the reality. So this is the latest report, and these are some of the areas where we're definitely not good. Frequent mental distress, premature death, economic hardship. Like we're one of the worst in per capita income, $28,000. And I think New Orleans per capita income is even less than this. Per capita income, or maybe it's household income in New Orleans, is one of the worst in the whole state of Louisiana. Like, would you think per capita income in Atlanta would be some of the worst in the entire state of Georgia? Or would the per capita income in Houston be some of the worst in the entire state of Texas? It's even counterintuitive as to how this even happens. I'll spare you discussion about multiple chronic conditions, but that's not good either. Some international comparisons. This you can't see is hidden up here, but this is infant mortality. in the United States, just to give you some more illustrations. So the best infant mortality rate is in Estonia, where out of 1,000 live births, you have 1.6 deaths. Here we have the United States at 5.7, and that isn't even this is the overall infant mortality. If you go in the Black and Hispanic community, especially the Black community, it's like twice this, sometimes 2.5 times this. So all of these other countries have a better health outcome than we have. I was in Slovenia in 2017 and 2018, and I had to chuckle with them. I said, I appreciate y'all bringing me here, but you know, your health status in every category is better than what we have. We can look at life expectancy. The longest life expectancy is in Japan with 84.2 years. Hawaii, 82.5, but overall in the US, 78.7, and in Mississippi, 74.8. And let's see, oh, yeah, I just did life expectancy. So this is health spending. This shows the amount of money that we spend. Almost $11,000 per person every year on health expenditures compared to these other countries. Everybody else spends considerably less than what we spend here in the US. And once again, here's our spending over here. Here's everybody else's spending way over here. And our life expectancy is way down here compared to everybody else who's way up there. So just the realities of what we're dealing with. I did want to talk a little bit. Normally I do this as a separate lecture about science policy, but I did want to get a few slides in here for you on science policy, because I have a lot of students in graduate studies at LSU. So they're not in public health, they're not in nursing, and they're not in medical school, but they have this real keen interest in policy. And I've lectured to them. I even have a postdoc working with me right now. She has a PhD in genetics, but she's very interested in policy. And before she graduated, I got her an internship at CDC, working in the genetics office. And now she's working with me and very much wants to go to DC and be a policy wonk. So people working in science policy take what is happening on the bench and bring it to the light of day into policy. Scientists are responsible for helping lawmakers and the public understand new and exciting scientific discoveries. You can think about what's going on right now with vaccine, and how the scientists, were the ones who developed that, but it had to be translated into policy, which is what is happening now. The challenge for scientists is that they're not policy wonks. They're not policy people typically. So when they have these novel discoveries, sometimes they struggle with, well, where does this fit in a policy world? So scientists must be deeply involved in convincing, framing, and implementing science policy. As scientists, it is not only their responsibility to perform and report evidence-based experimentation, it is also their responsibility to make sure the public understands the importance of those discoveries. A really interesting thing happened with science policy with the 21st Century Cures Act, public law in the 114th Congress, the 255th policy. But it's an excellent example of a national science policy effort. The legislation has many working parts, but the cornerstone of the bill is the $4.8 billion budgeted for NIH-funded research to be distributed over the next 10 years. Well, they probably have about 7 years left on this. I put this link down here. Anybody wanted to go and read more about the Cures Act. We really do need policy professionals. So policy professionals are guided by advanced training, not only in public health, economics, and formal policy analysis, but also medicine, law, blah, 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 blah. And a great example of that is Senator Bill Cassidy, who is considered as a policy wonk in the U.S. Senate. What kind of competencies do you need to be a policy wonk? Well, you have to understand the policymaking process. That is so critical. You have to be willing to participate, understand policy analysis and research processes. You have to be able to communicate quickly on a policy issue. In other words, give an elevator speech. When policymakers need information, they don't have time to wait for some academic to do a grant and get funding and then do the grant and then write papers. They don't have time for that, which is why a lot of policymakers don't even like the research process. It's just not conducive to policy making all the time. You also have to have good writing skills, which is why in my policy class at LSU, my students write policy briefs. That's one of their assignments. To build competencies in medical students, I created a health policy honors program where medical students can go to DC for 2 months in the summer. Although we couldn't go last year, they had to do remote work because we couldn't travel, and we can't travel this summer either. But they get placed in places like, this is Senator Cassidy. He takes somebody every summer. This is another one who was working with Senator Romney, Mitt Romney. But they get placed like in CDC policy office in DC, or the National Hispanic Medical Association, the Academy for State Health Policy, and committees like the Ways and Means Committee. Can't think of everything right now, but they learn policy. They absolutely learn policy. So now we're going to talk about the pathway to policy. I already talked about the 3 branches of government, where the legislative branch is where laws are enacted in Congress. The executive branch, which is where things get implemented. So the Affordable Care Act is enacted into law over here, and then they take the big 2,000-page document and send it to HHS and say, go forth and do good and implement this. You figure out what you have to do to implement it. And then you have the judicial branch, which continuing to think of the Affordable Care Act, when it was brought before the Supreme Court on many occasions to settle disputes about the constitutionality of what was in the Affordable Care Act. So now the context and the process. There's two sides to policy making, and this diagram, it kind of looks kind of confusing. It's not. They're trying to make an analogy between a policy market and the economic market. But anyway, you have demanders of policy, people who demand that, we want reform in health insurance. And then you have the suppliers are going to be the people who are the policy wonks, or Congress, or whoever, who is determining what those policies should be. And of course, it's all driven by values. And in my normal policy class, I have one whole lecture on values in the policymaking process. I don't have time to do that here, but values are very important because you can choose to establish the values of what you want it to be. And that will definitely influence what the ultimate policy is gonna look like. Demanders of health policy, anyone who considers policies to be relevant to the pursuit of health, or who considers such policies to be a means to some other desired end, like advocacy groups. And I think my next slide really talks about advocacy groups. They seek to change upstream factors like laws, regulation, policies, and institutional practices, prices, and product standards that influence the personal health choices of often millions of individuals, and the environment in which these are made. And you can think of, I talked a little bit before about mandates for newborn screenings. Parents who had children born with specific conditions that caused them lifelong disability really advocated for newborn screening policies, and especially over time, the expansion of those newborn screenings, because they saw their children having to live out their lives with these disabilities if only there had been a test at birth or shortly after birth that could have identified that health condition, and they could have been treated to avoid that disability or the disability to that degree. But that's one of the benefits of advocacy groups. I put this little bit of history in here because James Madison, one of the forefathers, described these advocacy groups as factions that were inherently bad. He defined them as a number of citizens who are united and actuated by some common impulse or passion or of interest adverse to the rights of citizens or to the permanent and aggregate interests of the community. So his thoughts would have been, well, these parents, they can't advocate for these newborn screenings just because they have an infant, because that might, be against the interests of the entire community. So as you can see, there was not consensus in government, just like there's not consensus in government now, unfortunately. Organizations do have advocacy agenda. You can go to the American Hospital Association and you can see their advocacy agenda. You can click on this link and see the advocacy agenda for the American Public Health Association. So next, I want to go through the conceptual model of the U.S. public policy making process. So this is kind of wonky, I will admit. So hopefully just stick with me and we'll walk through this. But this author, Buford Longus, I really like his depiction of this. Believe it or not, when in my doctorate program at the Medical University of South Carolina, we use this book. I mean, this is the 6th edition of this book. Probably when I was in my doctorate program, it's probably the 2nd edition because it was a long time ago. But this really helped me to understand the policy making process. And this is very important. Anybody who's going to work in policy, you need to understand this process. You really do. Not even if you're going to only work in policy, but even if you want to advocate for policy, you need to understand this process. And it all starts with the policy formulation phase. So, the first step in that is agenda setting. You need to get on someone's agenda. Standing in the hall, pontificating about a problem is not going to solve the problem. You have to get on somebody's policy agenda in the formulation stage. And you need to have a confluence of articulating the problem with a sense of urgency. You have to have some possible solutions, and you have to have a political circumstances that's going to allow you to push it through what they call the window of opportunity, where you would develop legislation, get it passed into law, get it in the implementation stage where it goes to the executive branch, and you have to design how it's going to be operationalized, how you're going to evaluate it. And then from there, and this could take years, the modification phase. Think of how many times Medicaid and Medicare has been modified. Even though it was implemented and passed into law in 1965, it's constantly being modified. And that's the entire process. I mean, I whiz through this quickly. It could literally take years to get this done. It could literally take years. But it has to go through that process. We talked about this, so I'm not going to go through that again. We talked about this. This is the window of opportunity where you have the confluence of these 3 things, and then you have people agreeing to, okay, let's go to the stage where we're going to develop some legislation. Factors impacting agenda setting. It's really problems reach an unacceptable level, interrelationship of problems, national sense of urgencies. All of these things impact the ability to get on somebody's agenda. The way it works in federal and state government is that these problems, health problems, are identified, let's say at HHS, CDC, NIH, whatever, same thing at state government. And at a certain time in the year, they bundle up all of these problems and their solutions, and they send them to, let's say, state. They send them to the governor and say, we would like policies. We would like to see some bills introduced to address these problems. And then the governor would have to agree that he thinks it's a problem that warrants attention through law, establishment of policy. Health policy will be treated differently when policymakers are preoccupied with issues of national security. Absolutely. At one time, right after 9/11, people used to say, you know, you can have a noun, a verb, and put in 9/11 and you can get anything done because of the sense of urgency. I think now you can have a noun and a verb and put in coronavirus or pandemic, and people at last are going to pay attention to what kind of system we need to mitigate a pandemic. President Obama realized that when we had the scares with Ebola in the US, and he set up a national office in the National Security Council. And their primary role was to track for the potential of pandemics across the world that could impact the US. And shortly after the change of administration, that office was dismantled. I'm not saying that's the sole reason why we have a pandemic, but everybody realized why that needed to happen back in, I don't know, 2008 or whenever, when that office was established. That was their sole role, was to track pandemics and prevent it from coming to the US. Political circumstances obviously play a role in either promoting or not specific policies. Development of legislation. It starts off as a bill and it's potential solutions to problems. And then it can advance to the next stage. The first step is to develop a bill that will travel through the process. Language in the law is very important to ensure that it is implemented and carried out with the intent of policymakers. I'm not going to go through this whole thing, but this just shows you the steps in the legislative process. It's very iterative and can be very complex. And all you have to do is watch the news and you can obviously see this. It's a very complex process to develop the legislation. And again, you can see here on the Senate side, on the House side, because it does go through both. And when you hear about a bill going to conference, that this is it right here. But it has to go through all of these processes before it could happen. And, you know, it could go through all of these processes and get killed right here. And look at all of the work that's already been put into that. Policy information, implementation. I'm not going to read through all of these, but there are 4 interrelated set of activities. You have the design, the rulemaking, the operation, and the evaluation. All of those are very key components to that. Operations just simply means the actual conduct of running the program. And that's really the domain of the bureaucrats. that's what the bureaucrats do. So as a, for instance, this is the healthcare acquired condition reduction program, because in section 3008 of the Affordable Care Act, it mandates that CMS establish a hospital acquired infection reduction program. So CMS had to figure out, well, what is that program gonna look like? How are we gonna implement that? They came up with something, and it was based on tracking healthcare acquired infection rates for hospitals based on some national averages, national standards, and hospitals that fell below that standard got a reduction in their Medicare reimbursement. And this was in 2015. There probably are hospitals that have been penalized since 2015, but this was the headline in the Advocate. 6 New Orleans hospitals face Medicare penalty for high infection rates. And this all came about in the Affordable Care Act. It said that CMS shall establish a program to promote the reduction of hospital acquired infections. Okay, that's how this came about. So this is actually taking the policy and it's operationalized through this program that CMS put together. Political competencies and places to influence policymaking. Well, there's several places where you can influence policymaking at the agenda setting stage, because you're identifying the problem, you're developing methods to evaluate the solutions, you're lobbying or advocating, but also at the legislative development stage. I've participated in both of these stages of policy, at getting something on the agenda, but also participating in drafting of the language, and then also testifying, and I'll show you in a minute. You can also be engaged at modification as well. So I'll give you an example of how that happened for me. And here I am years ago, 30 pounds heavier with short, dark hair at the time. But I testified before the U.S. Senate Bioterrorism and Public Health Preparedness Subcommittee. And I was asked, this was all part of the reauthorization process, so the Pandemic and All Hazards Preparedness Act. I was asked to testify on situational awareness, workforce, and public health systems research. And I was working with the committee advocating for public health systems research. So they asked me to come testify and try to build consensus where they could put money and language in the reauthorization of this act to support more research. So the testimony led to authority and appropriation in the Pandemic and All Hazards Preparedness Act with language specific for public health systems research. So I was a success. And as a result of that, a program was created at the Centers for Disease Control and Prevention. It was called the Preparedness Emergency Response Research Centers were created, and there was 8 of them. that were created across the country. Harvard had one, Emory had one, Pitt had one, Georgetown had one. I can't remember everybody who had one now, but as a result of my advocacy and working with the subcommittee, there was language provided, there was an appropriation provided, the money was given to CDC, and this is how it was operationalized. This is how the idea was operationalized. That's the end. Do you all have any questions about any of this? I know it was a mouthful. I know it was a lot. But I'm open to any questions that anybody might have.
You guys can use the chat box too if you don't feel like speaking out loud. Feel free to use the chat box. I'll read it for you.
I don't know if it's controversial or not, but kind of thinking on your work now, do you know what needs to happen or could happen research and policy wise around Cancer Alley and some of the environmental racism that's going on in the city, you know, with Garden Plaza and different, you know, residents who have for the longest time have been, you know, wanting to see justice and kind of look to public health as kind of like rationale behind, you know, why, you know, I'm sorry, I got stumbled up, but I can see your thinking. So I guess, yeah, what are your thoughts on that?
It's so ironic because I have a paper coming out any day now, looking at the COVID rates in areas of the world, including Cancer Alley, and the high rates of cases, plus high case fatality rates in these areas where there's high air pollution. And at one time, I haven't checked the data since I submitted the paper for publication, but St. John Parish here in Cancer Alley, I'm in St. Charles Parish, actually. I'm right next door. I'm in Cancer Alley too. But St. John had the highest case fatality rate in the US and higher than a lot of the other places in the world. It's shameful. So we do have the paper coming out, but there's other people who have written about this. Tulane has done work on this, the Tulane Environmental Law Clinic. I have a medical student who did his honors fellowship, policy honors fellowship at the Tulane Environmental Law Clinic. And his research and analysis and his report and manuscript are going to be on this very same topic as well. Especially here in the US, you get a lot of pushback from journals because they want clear-cut evidence of causation, not just association, but causation. And whereas in Europe, I'm not going to say that they're not as rigorous about this, but they're more open to publishing papers on this. And there's many, many papers on this in Europe. And someone in Europe even coined the phrase as slow violence. It's like, no, you're not shooting someone. Or you're not beating them to death with one stroke of whatever. You're slowly killing them.
Mhm.
It's a slow violence that's happening. And I am really very much into this, and I really am trying to work towards having some kind of legislative study committee implemented where we can look at, they're never going to approve a research to confirm causation.
Mhm.
They're never going to do that. But are there some other things that we can do? There's my cousin, General Honore. He established the Green Army. You can go look up Green Army. They're very active in fighting these people. One of the plants that they were trying to put in St. James Parish just recently got blocked. Or what they'll do is they'll try to put a plant in a predominantly white area, and the citizens in that area will say, no, we don't want to hear. Then they'll go to the minority community and get approval to put it over there. It's just inexcusable. It really is. What gives me some hope is that in Europe,
Mhm.
there was a little 8-year-old girl who was asthmatic, and she passed away. And for the longest, her mother fought because she really felt like the child died because of the air pollution that triggered her asthma. Well, at last, I think it's about 3 years after her death, they finally did the research establishing causation, and her death certificate has been changed to cause of death as air pollution. That's the first time that has ever happened in the entire world. The first time. It's also very interesting to me that the former governor of Michigan, the former director of public health, and some other bureaucrats have now been indicted and charged in the Flint water situation. So I mean, I don't want to be overly excited about this because I know how hard people have fought over these environmental conditions and have got absolutely nowhere. But I'm on it. I'm happy to be on it. I have a passion for it.
Thank you. That's good to hear.
That was a wonderful response. Good question. Thank you, Harmony. Anybody else have any, it's the great thing about this is that Dr. Honore, this is a twofer. So we'll be talking again next month. And so if you guys have foment questions over the next month, you all will get another opportunity to talk with her. And so, because we definitely did get a lot of wonderful information just now. Anybody else?
I have a quick question. It kind of ties into Harmony's question, but there was like a slide, I wrote it down. It was on slide 12 where it was like the research, or it was like the different causes of death in the US. And it talked about the social factors of death versus like other medical conditions. So I was just wondering, like, how do you create the data for like an example, for like a figure like that? How are they able to determine? Because I mean, we know that poverty and low education causes death, but kind of like you said, nobody's going to put like the cause of death on a birth certificate as low education. So how do they figure that out and put it together for the sake of having the data.
Well, yeah, I mean, so it all has to come from the data. I mean, so on a debt certificate, it has a lot of this information, and the information that's not on the debt certificate, then they go and get it from other means. Like another paper that I present in one of my classes is that they have the income data from IRS, like millions and millions data points to determine income level. So if poverty, personal poverty, they can tell that, but they have to dig deep to get this data. It's not an easy thing to get, but there are ways to get it.
Thank you. It's so interesting to me how, I guess, how they're finding ways to actually be able to connect it and make it actually like something people can see, because we know it to be true, but now it's like, here's the thing you can present to somebody to actually show them like this is actually true. It's not just us saying it, it's something that's presentable.
The most difficult part, even knowing it, is getting the policies to rectify it. We know income is related to longevity and health and well-being. We know that. So why can we not get a policy for a living wage? Why? We know. I mean, New Orleans, Louisiana, all across Louisiana, New Orleans in particular has some of the worst health outcomes than any place. And we know that income plays a factor in that, and we still can't get a policy for a living wage. So it's not just presenting people the truth or the data. We see that happening right now. What is the truth? Who won the election? Well, I don't believe it. You know, well, New Orleans has worse outcomes than any place in the state. And we know that income and poverty, over 30% of the children in New Orleans live in poverty. Over 30%. So we give them Medicaid expansion. We give them a card where they can go get health care, but then they're going back to live in the same impoverished condition. You know, and we just can't keep beating up on the medical professionals and the healthcare professionals. Say, well, the quality of care is not this and not that. Well, it's all these other factors also. I don't want to get on a soapbox, but some of this stuff just makes me so irritated and aggravated. I just want to scream.
I think I'm pro soapbox. I think it's a good soapbox. We got any more questions? Thank you, Arden.
Hi, I have a question. Okay, so you described Dr. Cassidy as a policy wonk. Can you tell us what a wonk is, and also why he is considered a policy wonk?
It's, well, the advocate called him, the advocate labeled him as a policy wonk, but a policy wonk in DC terms is a policy expert, someone whose profession is policy. Now, he's a physician who had a burning desire to be a policy wonk, or I should say a politician. So the advocate labeled him as that, but I call the medical students in my health policy honors program, I call them policy wonks too, because they're learning policy.
All right. Thank you, Nora.
I know Nora too. You're out too, Nora?
Yeah, I was supposed to go to Baton Rouge, but COVID happened.
Okay, so I had you last year, I think, or year before.
Hmm. Yeah, but you were also going to place me at Caritas Amera House.
Oh, okay, all right. Okay. Okay, so I'm ready for next time.
Great. Well, thank you so much for joining us.
Thank
If
y'all.
they could just raise their hands up and give her a hand since we can't clap. Thank you so much for coming.
Thank y'all. Y'all are a nice group.
We'll really look forward to seeing you again in a month.
Okay,
Thank you, Dr. Honore.
bye-bye.
Bye. Thanks, everybody.